Hi, and welcome to Medical Insights with Dr. Thomas Blom. Today on my episode, I'm talking with Dr. Michael Levitt, a medical oncologist with Hackensack Meridian Health and Director of Hospice Services for Swan Hospice in New Jersey. We're going to be discussing a very important topic that many patients think about during their journey with cancer, and that is hospice care, end-of-life care, and palliative services. I'm very happy to have Dr. Michael Levitt with me today. Dr. Levitt is a board-certified hematologist-oncologist practicing with Hackensack Meridian. He is also a director of hospice services, and today we're going to be discussing end-of-life care, hospice, and associated topics. So a difficult group of questions that patients often have, but some of the most important stuff that we deal with as medical oncologists. So Mike, thank you very much for joining me today.
Oh, thanks for having me, Tom. Appreciate it. Look forward to the discussion.
So when we take care of patients, especially patients with metastatic disease, patients who are undergoing active treatment, but we know that cure is not something that's going to be feasible, patients often have questions, even from the very beginning, regarding end-of-life care and what it may look like when their cancer progresses to the point that we no longer have treatments. And so, Mike, I wanted to start off our discussion by kind of getting a sense from you when you begin discussing goals of care, end-of-life circumstances, when you first meet a patient or as they're going along with their treatment.
Yeah, so these are certainly difficult discussions we have with patients, even for me, but certainly for the patients and their families as well. These are things we don't like to think about. They're certainly topics that we'd probably rather avoid, but certainly they're certainly needed and certainly important in the dialogue that we have with patients as we go through their journeys. Most of us don't think about end-of-life care, but certainly, we have to take reality and we have to think about it because it's important that we know what the patient wants in terms of what their wishes are, what they want to see their future to behold. And everybody has different goals in life and everybody has different wishes. So it's important for both me as a physician and for the family to really know what those goals are and what those wishes are, so certainly we can respect them and certainly honor them through their journey. I like to have those discussions, at least start to broach them early on, because they're things that we need to think about. They're certainly fluid, and they certainly can change over time. One day, maybe somebody wishes for a certain aspect of wishes in terms of their goals, and then certainly that may change at a later point as well. So I think certainly at least having those discussions earlier during our journey together certainly helps. Many of these patients become like family to me and my group and my staff, as I'm sure they do you as well, Tom. So they certainly, I think, put a lot of trust in us in terms of having that open discussion and, feeding off of my input as well. In making these difficult decisions.
Yeah, and Mike, you bring up a good point. You mentioned it sort of in the middle of your answer, which I appreciate very much. You brought up having these discussions with patients' families as well. And, one of the things that I've realized, and this is not the kind of stuff they teach in medical school, residency, fellowship, but you pick it up as you go along practicing, is that it's important to have these discussions. It's important to have it with the patient. And sometimes when you catch them when they're by themselves, they're more willing to open up. But it's also important to involve the family and the caretakers and their support staff, because often when there's, the healthcare team, us, the patient, and then the family, there may be sort of three different sets of perspectives. And you certainly can get into situations where family members and the patient themselves may not exactly see eye to eye on what the goals of care should be. So I think it's important to also, have the patient's wishes known by their family and their caretakers as well. So I think that's an excellent point. I didn't want that to let that go. But it's the kind of discussion, it's really a three-way discussion between patient, family, and us, physicians and the healthcare team. Now,
Yeah, no, that's a great point. That's a great point you make, Tom, because I think it's important to include the families, and we both do, and it's important to have everyone there. And sometimes we have 7, 8 people in the room, and the more the merrier. But I think it's important because it takes a lot of pressure off the patient as well. Sometimes they may just hear the first 5 words that we say, and then they forget everything else. So it's good to have everyone else there to provide their input as well, to help the patient through these discussions, because they're certainly not easy discussions for me nor the patient. And I think the more support the patient has, it certainly makes them feel confident in terms of what they're deciding, comfortable with that decision they're making. And certainly I think it just works out much better for the family, so they know what the patient wants. And it takes a lot of the burden off of them as well, because to put a family member and have them make a decision for their loved one, it's very difficult for them to do on their own. So letting the patient express what they wish, it certainly helps, I think everyone in that decision-making process.
Yeah, absolutely right. If the patient reaches a point where they're not able to make decisions for themselves, if the family knows ahead of time, what their wishes were, you're exactly right. It helps to ease the family's burden. So one of the questions we get, which kind of, piggybacks along with the goals of care, patients will often ask us, how much time do I have left? And that's a hard question for us physicians. So how do you approach that?
Yeah, so that's a number one question I always receive from patients, especially, we both see many cancer patients, and that's something they want to know, how much time. Obviously, at different parts of their journey, where they're at in their treatment, certainly, those discussions change. And the important thing is to be honest with the patient and their family. I'm certainly, very optimistic. Many times we're somewhat aggressive, and we certainly want to do well for the patient in terms of seeing them live longer and respond longer. But you also have to be honest and realistic with them, so they really know how much time they have, so they can plan time best for them for that time, to make sure that their family, and sometimes we have patients that have families in other states, even other countries, to make sure that they have time for the family to know, hey, it's time to bring family members in. I want to make sure they can spend time with their loved one. And so they can start preparing, for the time that they have. I think, honesty is always important. And like I tell patients, sometimes this is out of my hands, especially as that time becomes closer. I try to give them more not concrete time frames, but more days to weeks, weeks to months, months to years, rather than say, you have 10 days, because, those decisions really, are out of our hands. And our goal is to at least give them kind of a best estimate. And, we're not always right, but certainly I think, knowing the trajectory of different diseases and where they're at in their treatment certainly can give us perspective to provide to the patient.
Yeah, I agree. It's very hard to know, especially when you're meeting a patient for the first time and they're newly diagnosed, exactly what time frame the person has left. A lot of it, of course, depends on how they respond to treatment. We all have patients, even patients with diseases that have particularly poor prognoses, like pancreatic cancer, bile duct cancer, where they surprisingly beat the odds, and their treatment is going, better than expected. And then there's patients where, they have a disease that most of the time has a higher success rate of prolonging somebody's life, and things just don't go well from the beginning. And so a lot of it depends on, initial response to treatment and these sort of things. So, I try and counsel people that statistics are just that, they're averages. And a lot of it will depend on the pace of disease, how they're tolerating treatment, how they respond to initial treatment and those sort of factors. It can be very difficult to tell somebody who has a prognosis of about 2 years, anything better than an approximation.
Yeah, and you really need to personalize and individualize those discussions. Every discussion that I have or you have with a patient, it's certainly unique. It's certainly to put things in perspective for them. And it really differs, whether you're having that discussion for someone that you've been treating for 7, 8 years, or you're meeting them for the first time in the hospital and, they were newly diagnosed. So there are a lot of different variables, a lot of different, circumstances depending on where they're at, what their performance is, and certainly, what we think is their quality of life as well.
Yeah. So that brings me to the next set of things that I want to talk about. That's a good segue. A lot of times most of the time actually, patients throughout the course of their illness will have a sense that they're nearing the end of their treatment options or nearing the time when they should consider hospice or end-of-life care. But we of course have patients who are, really always, gung-ho and eager to try and continue to pursue active treatments. What are the kind of things that you look for as an oncologist to try and guide patients in the direction of end-of-life care, hospice care, when you're, looking at their scenario medically?
Yeah, so, as an oncologist, we're treating many patients with cancer. So one thing we're looking at is their performance status. So do we think they can handle further treatment? And the important thing I ask myself is that treatment going to do more harm than good? Certainly our roles as physicians is we don't want the treatment to be worse than doing nothing. We don't want the treatment to cause more side effects, more time either at home or even in the hospital. Obviously, we want the treatment to be beneficial. And obviously, patients need to have a good performance status. They need to be able to handle the treatment because many of the treatments we give, unfortunately, have a lot of side effects. It causes patients to be fatigued, to have loss of appetite, to have nausea, vomiting, diarrhea, other side effects where, they may be more miserable than the treatment than continuing it. So I think it's certainly important to put that into perspective, what the patient's performance status is and able to handle the treatment. The important thing that comes up very often is managing pain. So unfortunately, many patients from where their disease is located, they may have disease in their bones or elsewhere in their body, certainly may have pain. And it's important to make sure that their pain symptoms are managed appropriately as well. And I think it's having an honest discussion with the patient. Like I said before, you're really individualizing that patient and what their wishes are as well. And every patient, in terms of, it's hard for me to know how they're feeling and how they're doing at home. And we certainly have these discussions so that way we can have a mutual discussion and input in terms of where they feel they're at in their treatment and whether they want to continue to pursue further treatment or not. They certainly take my input as well in terms of, into consideration, but it's a joint process, and it's really, I try to get to know the patients and their families very well so that way we can have these honest discussions together.
Yeah. Right. A lot of it depends on the intensity of treatment options that still remain. For patients that are, for example, being treated for breast cancer, if we have hormonal therapy options or things like that are relatively low in terms of toxicity, then there's, if the patient is still active and able to, do things that they consider, maintaining quality of life, then there's, very low risk to continuing treatment, even if that treatment is, not ultimately successful, because we're not really, doing any harm. First rule of medicine, do no harm. But if the patient has advanced cancer and they've been through multiple lines of chemotherapy, and all that we have left is other aggressive chemotherapy drugs, and you really have to weigh, how sick is the patient going to be compared to what we might get in terms of benefit. And if it really is reaching, futility, then, that it's important for us to explain that to patients and say, listen, you're probably not going to get much yardage out of this treatment, but it might make the time that you have remaining, considerably more miserable. And try and guide them in the direction of hospice care. Even in this situation, if patients are, still wishing to undergo therapy, it's our responsibility to make those, very, very tough decisions. And sometimes, if patients really just aren't quite there in terms of how they view their disease, it's helpful to get second opinions and things like that, just to see what, other oncologists might do in that situation and see if they're all on the same page for what we're thinking. I wanted to touch base, on, you had talked about managing patients' pain and if they have bone lesions and stuff like that. A common question I get, either as patients are approaching end-of-life care or sometimes in the middle of their treatment, is about palliative care versus hospice care. And so, as oncologists, we feel like our job is to provide, palliative care throughout. We're prescribing pain meds, we treat their nausea, we try and manage their symptoms. But a lot of patients inquire about a formal, palliative care program. So how do you incorporate that? How do you counsel patients on the utility of palliative care services?
Yeah, so I think it's an important distinction because many patients, families are unaware of the differences between palliative care and hospice. Being on palliative care means you can continue your treatment. So whether you have cancer and you have breast cancer and you're on hormonal therapy, whether you're receiving chemotherapy, you're able to continue your treatment while on palliative care. And it's more of an adjunct, and we work together with the oncologist and the palliative care team in managing those symptoms and that the patient may be experiencing. I look at palliative care more like a bridge. Typically, patients start with palliative care and then transition to hospice when they're not candidates for further treatment and they want to focus purely on supportive care only. So the important thing for most patients to recognize is that you can still be receiving your treatments and be receiving palliative care as well. At our hospital, we have a palliative care team at our office that we refer patients to. They meet with the patients and they help the patients in terms of symptom management. So if the patient is having pain, certainly we're able to manage their pain, but certainly they're also working with us in conjunction to manage their pain. If they're having GI symptoms, if they're having depression, anxiety, which many patients experience, they'll help to manage those symptoms that the patients are going through as now. Another important aspect that they help with is creating a POLST. I think we may talk about this a little later, but certainly it's important.
I think it's a good time to bring it up.
Yeah, so it's important for patients, like we were talking about before in terms of goals and wishes. A POLST form is putting in writing what those wishes are. And those go onto the chart and they go into the patient's medical record. And certainly the family has that as well. And there's certainly wishes to know what your advanced directives are. Do you want to have heroic measures such as being put on life support, being put on a ventilator if you're unable to breathe, having compressions performed if your heart stops? These are important for patients to think about because it's important for us to know if the patient is hospitalized, what those wishes are, and it's important for the family to know what those wishes are as well. This includes artificial feeding as well. Does the patient want a feeding tube if they're unable to swallow or take nutrition? So they're a tremendous asset in terms of our palliative care team. I certainly try to involve them very early on, many times at diagnosis, because it's important for the patients to work with the palliative care team. I find those patients that are working with them tend to do better because they have a whole support system in terms of not just the palliative care physician, but they have additional nurse practitioners, they have social workers, they have psychologists. So they have a really big team that helps support the patient. And like we said before, this journey is very difficult, and it needs a lot of support and a lot of people involved. And it's important to have the resources to really help the patients, I think, overall do better and just have a better experience as they're going through their treatment.
Sure. And it does take a team to take care of patients, and it helps us as the oncologist as well. There's a lot that we manage in terms of the disease itself, treatment-related complications. There's a lot of decision making, and it's helpful for us to also have another member of the team to address symptom management and those sort of things. I find that, sometimes patients view me, I believe, differently than the palliative care team. We talk, more nuts and bolts of their care, whereas patients are more willing often to open up to the palliative care team about some of the more sensitive symptoms that they're having, with regards to, bowel function, bladder function, incontinence, different pain symptoms, talking about, things like sexual function and things that, are part of patients' lives, even when they're going through cancer. So, each person has an individual role, and I think getting them involved as soon as possible is very helpful to the patient and to us when we're, managing their disease. So just to reiterate, I think one of the important points, under palliative care, it's in addition to whatever we're doing to manage their cancer in terms of treatment. And that's a big distinction between hospice, where certain medical services are no longer available because the goal is entirely switched only to symptom management, whereas under palliative care, there's two goals. One is to manage symptoms, and the other is to actively treat the disease.
Yeah, and that's an important distinction for patients and families to recognize, because there's always a lot of confusion and there's a lot of misdirection that patients think that palliative care means we're stopping treatment and we're just focusing on comfort. And that's really not the case. And, I look at the palliative care team really as an adjunct and really a support system for the patients. And they're just, another arm helping us manage the patients and really giving them the care they need in terms of managing those symptoms. So, it's important because, there's definitely a lot of misdirection, and a lot of people don't really understand what palliative care is. And not that they would, because, until you're put in this situation, you really wouldn't maybe ever be introduced to a palliative care program unless it's, a family member or a friend or a relative. It's important as well that palliative care isn't just for patients with cancer as well. Certainly, me and Tom, we do a lot of cancer, but there's other illnesses, and there's many of them that we deal with that are chronic conditions that palliative care manages as well, whether they're end-stage cardiac conditions, whether they're respiratory illnesses, whether they're different infectious illnesses, whether they're different rheumatological autoimmune disorders. So, it's the whole gamut of medical problems and chronic illnesses that palliative care can assist with. And certainly we see patients with many other different medical conditions as well, and they certainly, are available and they help to manage patients and symptoms as well.
That's a great point. We as oncologists, we think, primarily about the diseases we treat, but you as a hospice director, palliative care director, see all sorts of other chronic illnesses that certainly have, an end stage component, a very important need to meet. When a patient transitions to hospice, what are the kind of services and treatments that you're able to continue, and what are the treatments and interventions that are no longer allowed under the umbrella of hospice care?
Yeah, so that's a great question. I think it's important discussion so patients and their families understand what is entailed on hospice. So when patients go on hospice, it means we're not pursuing further treatment. And by treatment, we mean if patients are receiving chemotherapy for their cancer, we're stopping those more aggressive treatments. If patients are, going to receive blood transfusions, for example, we're usually not continuing on with those transfusions. So our focus on hospice is not doing the more aggressive treatments, doing the treatments to manage the disease process. Instead, we're switching our focus to manage the symptoms from the disease. So like we discussed before, we're managing the pain, we're managing the GI symptoms, we're managing potentially respiratory symptoms, and really our focus is on comfort for the patients. Hospice can be in different places. Some patients opt for hospice at home. Patients who are kind of limited in the time they have or their symptoms are unable to be managed at home are managed in the hospital. And then there are very few in New Jersey, but there are some hospice facilities where patients are managed in an outpatient hospice facility. When patients go on hospice, I tell them they're not losing me. They still have me as their physician. I'm still involved in their care. Many times I'm still the physician on record for them. And to me, it's a preference because I know the patient, I have a relationship with the family, and I still want to care for them through the rest of their journey. So the nurses, the staff that is evaluating the patient is going out and calling me and advising me of the patient's condition, if we need to change their medications, their pain prescriptions. So I'm still constantly involved in the patient's journey. Patients also in hospice can still go back and see their physician. So just because you're on hospice doesn't mean you can't come for an office visit. Again, the visit's a little different in terms of our discussion isn't focused on what treatment are we doing next, what is the scans and imaging look like. It's more focused on, okay, how is your pain? How are your symptoms? How much are you eating? How is your sleep? And what things can we do to improve your symptoms at home? So it does change in terms of the perspective, in terms of what the goals are. But certainly, at some point, that we have that transition, and it's important for patients to transition to hospice so that way we can give them support, we can give them dignity and respect during that time when we're not pursuing, further interventions and treatment.
Yeah, the comprehensive nature of hospice is one of the real benefits to it. And you as their physician, me as their physician are still part of that. We sort of become part of that comprehensive team. We're adding hospice nurses, we're adding, supportive care through social work, clergy if needed. Hospice, we remove some of the elements that we've been using to treat their disease aggressively. Chemotherapy, radiation, blood transfusions are not given, but then we're adding, and one of the things that I think patients are pleasantly surprised about, and families for sure, is that the ease in which we can get other supportive measures, where before it can be very difficult to get home care, it can be, difficult to get, medications quickly, especially narcotic pain medicines if needed, or anti-anxiety medicines. It can be difficult to set up home oxygen. It can be difficult to get, durable medical equipment, commodes and beds and all that. When hospice comes in, it's easy. They can do all that stuff. We don't have to piece it together one at a time. We don't need to individually get insurance approval for those things. And so, even though we're removing some elements that have been part of their care, sometimes for years, like chemotherapy and stuff like that, we're adding all of this supportive stuff, which comes in quickly, readily, and can be, needs can be responded to with much more efficiency than when a patient is not on hospice. So it's we're not really giving up anything, in my opinion. We're gaining, because we have the better ability to take care of the patient for where they're at in that point of their care. Whereas before, even under palliative care is excellent, but sometimes it can be difficult, because you still have to, everything has to be approved individually if you're, adding home care services and things like that.
Yeah, that's an important point you make, because when you're on hospice, there's additional benefits that are paid out from insurance, and those provide for the durable equipment. So many patients and families may need a hospital bed in the home, and it certainly makes their life much easier. And that's included. There's other durable equipment like a commode, a bedside table, that's covered by insurance. And that also includes if the patient needs oxygen and other durable equipment needs. The important thing to recognize with hospice is that it is a team approach. So it's not just a physician and a nurse going out. We have social workers that are on the team, and they're going out to meet with the patient to see what needs they have, to meet with the family. And it's important, that the families are involved in the process. Like you had mentioned, we have clergy. So faith is very important for many patients, especially during this time that they're thinking more about their faith, and they're thinking about, kind of their next journey. And certainly our pastors are very supportive in praying with the patients and finding different clergy, whichever denomination they are, to be able to be part of that process as well. We also have a volunteer coordinator to come out. So some patients need additional help. They need someone just to sit with them, to talk with them, maybe play cards with them, just to spend time. So we actually have a team of volunteers that will go out either to the house, or if they're in a facility, to spend time to provide additional help as well. There's aides on the team that will come out to provide additional assistance to the family, whether it's bathing, dressing, preparing meals. It's important to have them involved as well. So, we have a huge team on hospice, and we meet every 2 weeks. We go over we review all of the patients that are on our team, and we discuss them. But it's not just the physicians, the nurses. It's a lot of people involved, and there really needs to be, because it's really, like we said before, it's really a team effort in managing the patients at every point in their care, and particularly at the end of life portion of their journey.
The one thing that I wanted to add to that is that patients will ask me, will insurance cover this, or what do I need to qualify for hospice? And I'll just answer this quickly in the sense that essentially all insurances will cover hospice care. And really the only main criteria that's needed is that you or I or any physician just needs to certify that a patient's prognosis is less than 6 months. And they don't hold us to it. This is something, as we talked about in the very beginning of our discussion, oftentimes the best we can do is give a ballpark. But if we believe in our professional opinion that a person has less than 6 months to live, and we sign off on it, then hospice, in my experience, has never been denied.
Yeah, and the other point I'd like to make too is, once you're on hospice, it's not a kind of fixed place that you're at. So there is the ability to come off hospice. Now,
that's a very good point.
Does it happen that often? It doesn't, but certainly I can think of 1 or 2 cases where, for whatever reason, the patient actually improved and didn't qualify for hospice. And some patients actually do better. Sometimes it may not be cancer patients, but they may have other disease states. We have patients with dementia, and, they may go into the hospital with an infection. They have a decline in their performance. They go on hospice, and maybe once that infection resolves, they're back to their baseline again. So when we're having discussions and we're discussing the patients, we're also seeing whether they're appropriate for hospice. And there are times in that time frame where the patients may be doing too well, where either we need to take them off or the family opts that maybe they're not ready for hospice and they decide to take them off. So it's not
that's a great
fixed point. Yeah. The other thing too is there's many different hospices. So like if you're shopping for cars or you're shopping for anything else in life, you can choose and shop for hospices. I'm director for one, but I can think of 5 to 10 hospices within our local area that provide that care. And it's important to meet with hospices, whether their opinions from the maybe personal, family, friends, hospital, social workers, or the physicians involved. But it's important to meet with them because you want to make sure that you're comfortable with the services you're receiving and that you're confident with them as well. Even while you're on hospice, if for some reason you're not getting the care that you need, you can always switch to a different hospice. So patients have that ability and families have that ability as well to make choices. And it's important that they make the right choices for their family because you really want to be getting the care that you need at that point in life.
Right. So before we move on, the two things that I wanted to ask you, one is regarding feeding. So something that usually creates very little anxiety for the actual patient themselves, but typically a tremendous amount of anxiety for the family, especially a spouse who may be the one who typically prepares meals for the family, is if the patient is no longer interested in eating. So I get questions about NG tube feeds and TPN and those sort of things. And how do you counsel patients with regard to that topic and families?
Yeah, so they're difficult discussions we have, in perspective for cancer patients because, there's times where patients are losing weight, they're not eating, and families may ask, should we put a feeding tube in? They've done studies that showed that doing artificial feedings, is more feeding the tumor than actually providing nutritional supplementation to the patient. And many times, we may or may not provide the artificial feedings, but I find that it doesn't extend a patient's life and it really, doesn't add more to that patient's quality of life either. So again, we personalize those discussions, but I haven't found them to be, at that point in their life, it really doesn't extend meaningfully that patient's life. Now, there are patients for different, other medical conditions, again, whether they have, dementia, whether they have dysphagia and unable to swallow that. We do have patients with chronic illnesses that do have feeding tubes and receive artificial feedings. And those patients can continue their tube feedings while on hospice. And certainly we continue them. And certainly we have discussions at times too, where maybe we want to discontinue those feedings as well. There's another type of feeding that we give intravenously in the hospital and at home called TPN. There are additional intravenous nutrition that we sometimes give patients if they're unable to have a feeding tube, for example. Many times when they're on hospice, even though they could receive TPN, we usually discontinue those services. There's a lot involved in preparing the nutritional supplements. And again, we're really trying to transition our focus more to doing the more aggressive therapies, to doing therapies that are focused more on comfort and support at that point in their life.
Yeah, great. That was excellent synopsis of a common question that we face. The other question that I get is hospice care 24-hour care? And so, can you explain the scope of hospice with regards to how much support comes to a patient's home and address that question regarding how much availability of nurses, aides, nurses, and that sort of thing?
Yeah. So, when a patient, I refer a patient to hospice, we have our social worker, case manager, and nurse come out to meet with the family to kind of understand what hospice philosophy is and what is provided in terms of the services. And like I said, it's a whole team that's involved in those services, but those services at home aren't 24/7. So the nurses are on call 24/7 to be able to provide services. So let's say if it's at 1 a.m. and the patient is having exquisite pain and maybe is having air hunger or really needs support, those nurses will go out on call to evaluate the patient. During the week, the staff is going out several times a week, and the aides are going out as well to assess the patient to see what needs there are. But that nursing and aid care isn't provided 24/7. And unfortunately, that burden is placed on the families to either provide that additional care, or many families sometimes need to hire additional help and aides to provide that additional care to the patient, especially if they're unable to do their normal activities of daily living, like bathing, dressing, feeding, etc. When the time comes as they go through their process, when it becomes more imminent, at that point in time, we typically bring in around-the-clock hospice care when we feel that their time is in days and they're having additional symptoms, they need additional support. Many times at that point, we'll be able to bring in additional care 24/7. So that discussion is part of what our initial social workers and nurses discuss with the patients and their families, because it's not uncommon that many families, even though their goal may be to keep their patients and loved ones at home, it may not be realistic. We have many patients that when we can't care for them at home, they'll go into a facility such as a nursing home type of facility where at least they'll be receiving additional care there. They'll have additional nursing care, and then they can also receive hospice care at the facility as well. So there's many rehab nursing home facilities throughout the state of New Jersey that we have patients on hospice, and it takes the burden of caring for the patients away from the families having to do that, and the staff at the facilities is caring for the patients at home. The third approach I talked about earlier is for patients that are in the hospital, and typically, as she said, when we find a patient is appropriate for hospice when they have 6 months or less. When they have 2 weeks or less, when we feel their symptoms are imminent, those patients are typically appropriate for inpatient hospice. And at that point, they're being managed in the hospital. They're receiving around-the-clock care by the nurses in terms of managing their pain, prescribing their medications, and helping them when they during that short period of time when they have limited time with us.
Yeah, a great summary. I think that those different options help, patients and families to decide what specifically is best for them. For home hospice, if a person is not in what we call the active phase of dying, the feedback that I get is oftentimes families appreciate that it's not 24-hour care because they do want some time just themselves, either with other family members, friends, or just, a couple. And they don't want, around the clock, nursing care because it's not necessary. But as a person begins the active dying process, the ability to bring in 24-hour care for that time period, or to transition if needed to an inpatient facility, respite type situation, can be very helpful. It's flexible. Hospice is not a fixed organization or decision. We have a lot of tools at our disposal. Hospice has a great arsenal of tools to help people in various different ways and meet their needs. And quite honestly, when you brought up the fact that there are, 5 to 10 hospices in the area that you practice in, I have actually not ever received negative feedback about any of the hospices in our area. So, you may choose as a family or a patient one over the other, but I've not encountered a single hospice where a family has told me that they did not do an excellent job to meet their loved one's needs.
Yeah, no, they all provide excellent services, and But it is a choice, and certainly you may hear, one friend recommend one and another friend or family recommend another, and maybe your doctor recommends a third. They're all providing similar services, and they really provide excellent care. And I've certainly been director of one hospice, and then I've worked with the same staff at another hospice. So a lot of the people that are in hospice have been doing this for many years. Many of them are former nurses in the hospital or in different, practices throughout the state. And they've really, really been doing this for a long time. So they really, really know how to manage patients, and they really understand hospice. The other point I wanted to make in terms of flexibility with hospice, many people think, well, I'm on hospice, I'm just going to stay at home and I can't really do anything. You certainly can do whatever you're able to. And again, that is on a individualized basis. But say, I want to go out to dinner. Even though you're on hospice, you could still go out of the house and go out to dinner with your family or friends. Or you can go, if you have an event, a holiday coming up, you can still spend it at someone else's house. So again, that perspective may change as maybe the patient is unable to do those certain activities, but no way in terms of hospice for many patients means that you're just at home. What that really means, especially initially, is that we're just changing the focus in terms of what our goals are and what our really direction is in terms of the type of care we're providing.
Yeah, outstanding point, because that actually is I think the main reason why people have reluctance to going on hospice, even when they've exhausted the treatment options for their disease. So that's an outstanding point that you bring up. You're not trapped at home, waiting to pass away. You can, whatever you feel up to and are able to physically tolerate, there's no limitations.
Exactly. And really our goal really with hospice is that support, and that to be able to transition with dignity and respect during that part of their life. It's always heartbreaking for me to see a patient in the hospital and we're doing tests and procedures, and that really isn't going to extend their life, but it's certainly taking away that time that they could have been spending at home with their loved ones in their common space, rather than being, doing all these tests and then, having to go through that dying process in pain, not really having great quality of life. And that's why we have these discussions, and that's why we have hospice. And unfortunately, there is somewhat some misconception about hospice, but really that's our goal, is that patients can have a dying process, that they're having comfort, they're having the needs that they need, and they're doing it the way that they want it.
So Mike, for patients who are experiencing symptoms of pain, nausea, decreased appetite with their journey, with their battle with cancer, commonly we get asked about medical marijuana, which in the state of New Jersey is now legal, and legal in many other states, and has become, an important adjunct to what we're doing. So what is your experience in prescribing medical marijuana, and what, potential benefits do patients experience?
Yeah, that's a great topic to discuss. So I look at medical marijuana as an adjunct to their care. So many of us are familiar with pain medications like oxycodone or Percocet that we're prescribing for patients, or maybe they're having nausea and we're giving them antiemetics. And sometimes their symptoms aren't very well controlled, or patients may not prefer to use those prescription medications to manage their symptoms. And they ask me about medical marijuana. There's certain eligibility that patients need to have. So they need to have a chronic illness, and they need to have a condition where they would be eligible for medical marijuana. Like you said, it is legal in the state of New Jersey, and there are specific providers that are enrolled in the New Jersey State Medical Marijuana Program. I enrolled in the program to be able to provide these services for my patients. As a physician, you go through a course, you have to answer questions, and then you become enrolled in the program. And if you go onto the New Jersey State Medical Marijuana Program, there is a database of physicians in different disciplines who are eligible to prescribe. And it's not just oncologists like myself. There's cardiologists, there's rheumatologists, there's pulmonologists. So like we said, there's many different chronic diseases where medical marijuana certainly would be appropriate. When I evaluate a patient, or whether they ask me whether they're eligible for it, we certainly see if they meet the eligibility criteria, and then I discuss with them what the benefits are. And certainly it can help with their symptom management, managing their pain, managing their GI side effects, such as intractable nausea, vomiting, helps with anxiety, depression. And if we feel that that would be a good fit for the patient, I fill out a kind of enrollment into the program. I have to put some of their demographic information, the quantity of marijuana, and for the length of time. And then I submit it and they get a case ID number. I give them a printout of the information. The patient then goes either at home and either alone or with their family, and they have to fill in their own information in order to enroll. And then once they're enrolled in the program, they'll receive a kind of like a driver's license that they'll receive from the state that shows that they're enrolled in the program. They can then go to different medical marijuana dispensaries in the state and certainly, obtain the marijuana. The one thing important to remember is that it's not covered by insurance. So again, they do have to pay out of pocket. Many times, because it's a medical condition, one, they may receive discounts than just going in for medical marijuana without the prescription card. And two, certainly they receive a priority, if certainly there's a limit in terms of where maybe the supply is in the state. This was more early on when these programs and dispensaries were first upcoming. They certainly receive a priority as well. And it's important to remember that patients can receive many different types of medical marijuana, whether it's the type they smoke, whether it's the edible types. And when they go to the dispensary, they'll meet with the staff there, and then they'll talk about what their symptoms are, what their needs are, and then determine what would be best for them. But I have many patients that find that it helps with their symptoms, and they really find it useful. And my goal as a physician is to provide resources and for patients that certainly can help them kind of manage their symptoms better and get them through their treatments with less side effects and toxicities.
Yeah, it's like any other pharmaceutical. You see if the patient needs the specific medication for the condition that you're treating. There's pros and cons and potential side effects to anything that you do. Oftentimes, patients with chronic pain find medical marijuana to be easier to tolerate than escalating doses of narcotics and other medications that may have, significant other side effects. Medical marijuana has been legal in the state of New Jersey for some period of time, but I'll tell you, as long as I've been practicing, even before medical marijuana was legal, people were using medical marijuana. Probably it's been used for hundreds of years or thousands of years before, there became a official, legal way to obtain it for medical purposes. So, provides a level of safety, provides a level of accountability. It's good because there's education for patients and physicians. And, it's really another tool to help people, especially, when they're entering the phase of their illness where they're having, more and more symptoms. So thank you very much for coming on to talk about hospice and end-of-life care. It's a difficult topic for patients to discuss, but near 100% of people who are faced with a cancer diagnosis, I think at least at some point, think of issues regarding end of life, death and dying, even if they have a prognosis where, thankfully they are going to do well with treatment. I think simply the diagnosis of a malignancy brings to mind these thoughts. So really helpful for me to hear your perspective. I learned a lot from the discussion, and I hope that the patients who are watching this will also have learned a lot. So thank you Mike, for coming on today.
Yeah, no, thank you, Tom, for having me on your show. And certainly, even though this is a very uncomfortable topic for most people to talk about, I'm really happy that you brought this to the attention of a lot of patients and families, because it is very important. Hopefully this helps to erase some of the stigma that hospice and palliative care has. And I think it certainly helps patients, have a better understanding of it. Families know what the expectations are. And I think if, the patient or family needs to have those discussions, I think it makes it easier for everyone. So, yeah, I appreciate you having me on today. Thank you again.
You're very welcome, and hope to have you on again for another episode.